Hi, I'm Mark Rabin. Welcome to My Favorite Mistake. Our guest today is Tiffany Auvil. She has spent more than 20 years inside the US healthcare system, starting as a volunteer firefighter, then an EMT, then an LPN, then a registered nurse, and eventually system director of outpatient clinics for a three-hospital health system. She's also a functional medicine health coach. She's finishing a doctorate of science in integrative healthcare, and she's the author of the book, The No BS Guide for Caregivers: How to Survive the Healthcare Maze. So, Tiffany, thank you for joining us. How are you?
I'm well. Thank you very much for having me today.
Yeah, well, it's great to have you here. There's a lot to talk about later in the episode about your book, your recommendations and advice for others, your experiences working inside healthcare. But as we always do, first here, Tiffany, looking back at things, what's your favorite mistake?
So, my favorite mistake would be trusting the system that I had worked in for so long when my husband was diagnosed with cancer.
Mhm.
Um, and I learned through that process that even though we take so many safeguards inside of healthcare to make sure that our patients are cared for, people slip through the cracks, and sometimes things happen, multiple times to the same person as what we experienced, and, that was what led me to write my book.
Yeah. So, what came to light when you talk about flaws in the system? Yeah, I'm sorry to ask, but what did your husband experience? What did you experience as a spouse and a caregiver?
Yeah, so, my husband actually first was diagnosed with renal cell cancer in 2016, and we were lucky at the time. He had a total nephrectomy, which was even done by robotic assist. He was discharged the next day, and after 3 months of recovery, he was cancer-free and doing great. And then 7 years later, he started having some vision problems. And we kept going back to eye doctors. Nobody could figure out what was going on. So his PCP and I, who worked together, started talking, and we were like, let's scan his head. And since renal cell cancer mostly metastasizes or reoccurs in the abdomen or chest, then we also had to scan those areas as well, and
Mhm.
found that his cancer had returned. This was in January of 2003, and it was in his pancreas and his liver.
Oh no.
And yeah, he was 39 when he was first diagnosed, and so this was 7 years later. He was 46, and I went straight into wife, caregiver, nurse mode, making sure, like, he had everything he needed to get into the doctor's appointments. We decided to go to the same facility that had treated him before for his cancer. This time, instead of just seeing the urologist who removed his kidney, now we're in oncology because now we're at, we're gonna need some actual medications, which he didn't have to have
Mhm.
this time. And planning all of that, and then the night before his first immunotherapy, I got a phone call from the nurse that worked with the oncologist saying that our insurance had denied his immunotherapy and that they were gonna have to reschedule his appointment for the next day until they could get it figured out.
Huh.
I have worked with insurances for years. I've done prior authorizations. I've Back in the day when before there were portals, when you were on the phone 45 minutes to an hour and a
Mhm.
half waiting for someone to pick up,
Mhm.
had
Mhm.
those, and I was like, "No, no, my insurance was great. I didn't require prior authorization for an MRI. I don't see why they're gonna require a prior authorization, let alone deny immunotherapy." So I told her, "I'm gonna call my insurance company and find out what's going on, and I'll call you back. Don't cancel anything." And, I called my insurance company, and they were stumped. They didn't have any denials in the system. They don't deny prior authorization, or they don't deny immunotherapy. It doesn't require a prior authorization. It should be one of ones when they enter in the portal, it's just automatic do. And so I was like, "All right." And having known what I knew before I even called my insurance company. I had looked up what the J code was for Keytruda because that was the medicine he was supposed to have. I knew what his ICD-10 code or his diagnosis code was because I can get it from the portal, and
Mhm.
so I knew what to talk to the insurance because they don't talk in plain language, they talk in
Not everybody knows
and
even what ICD-10 code is, yet alone what's the code. So you had that advantage, but
So I
yeah.
had that advantage, and so I called the nurse back at the oncology office, and I was like, "Hey, I just spoke with my insurance company. I gave them this J code for Keytruda. I gave them this ICD-10 code for metastatic renal cell cancer. Even without those codes, there should be no prior authorization needed. There's no reason for him to have been denied. We will be there tomorrow at 9:30." So I was very adamant, like, "We are coming in tomorrow at 9:30 for us to be."
Yeah.
And she's like, "Okay, I'll let my prior authorization specialist know. Thank you very much." And I was like, "All right." So I was still at work dealing with this, as those of us who are in the system are always dealing with things.
Uh-huh.
And about 10 minutes later, she called me back. And she was a very nice woman, very nice nurse. And she said, "Tiffany, I'm so sorry to bother you again." And I was like, "You're fine. What's going on?" She said, "I spoke to my prior authorization specialist. And the code that you gave the insurance company for the Keytruda was the wrong code." And I was like, "Wait a minute. There's only one code for Keytruda, like, I knew this." I said, "Well, what code did she say it was supposed to be?" And she rattled off the ICD-10 code.
She got it mixed up.
The prior authorization specialist got
Ah,
the 2 codes mixed up. So when she was putting the ICD-10 code in the spot for the procedure or the medication, it was kicking it out saying denied because it wasn't even a real code.
makes sense why it got kicked back. Uh,
Yes.
yeah.
I was rather upset, but happy to have figured out what the issue was, and I told the nurse, I was like, "Look, don't take this the wrong way. I want you to know, and I know this is not your fault, but please call your prior authorization specialist back and let her know that if she would use the actual J code in the spot for the medication, that it would work, but the code she's trying to use is a diagnosis code, and if you need to, give her my cell phone number. I'll be happy to walk her through how to do her job." That was the nicest way I could say it at this
Well, it's a stressful time, and it shouldn't have happened,
very
right?
stressful
Yeah.
time.
Yeah.
And so I went home and I told my husband about it. And at first, he's worried. He's like, "Oh my God, you said that. They're not treat me good anymore." I'm like, "No, that's not how it works. Like,
Yeah.
hospitals get paid on patient satisfaction surveys. Like, they're gonna always treat you good." But we got to the oncologist office the next morning, and the oncologist was ecstatic that somebody figured it out. She
Yeah.
had so many people that she had denied prior auth chemo or immunotherapy, and she could never figure out why, though they won't say it. She was wondering if this was the reason.
That same mix-up was happening all the time?
It seemed that way. And so, and I had the knowing what I knew from healthcare, I went straight through the grievance process. Even though it was thick, I went
Mhm.
and told the patient advocate, made a grievance on it because I didn't want it happening to someone else again. And
Yeah.
if things are reported, then, the same mistakes can happen over and over again because nobody realizes it's a
Or people don't push back, people don't fight, people don't persevere.
yeah.
I mean, it makes you wonder how many people had delayed care, or I hate to think they didn't get it.
Yeah. Well, and this wasn't the only time we had trouble.
Mhm.
So a year later, it appeared that my husband had metastatic brain cancer. So
Mm,
looked like the renal cell cancer had spread to his brain.
yeah.
Though the treatment for that is gamma knife, which is when done for the appropriate thing, very safe. You can even go to work the next day. And for
Mhm.
anyone who doesn't know what gamma knife is, it's like very precise radiation into. And so 2 days before his gamma knife appointment, I got a phone call from the clinic, again, this different clinic this time because it's radiation oncology, telling me that the insurance had not yet approved the gamma knife procedure. And this had been just about 2 weeks since it was supposed to have been submitted, and I know prior authorizations from an insurance side can take up to 2 weeks to be obtained. So I was like, "Let me call my insurance company, let me push, see what I can get done, because we got a couple days here, we'll see." I called my insurance company and they couldn't find a claim. And so I was like, "They're telling me that you guys aren't doing anything. Can you help me figure out what's going on?" So after about an hour and a half, 2 hours of the insurance representative digging through things, they actually found the claim was still sitting in the portal, not yet,
Mhm.
because it didn't have clinicals attached to it.
And what does that mean, not having clinicals?
Like having a diagnose like a doctor's note, like the so it was never like the clinicals were never attached, meaning the note from the office visits, and the person who was working on it never hit the submit button.
Ugh, these all seem like such preventable mistakes. Not to sound judgmental about it, but it's probably a fact to say these are preventable.
I would feel preventable, even if something like that, just double checking your work or having someone double check it. I know one I was fortunate enough last year or the year before to be part of the West Virginia Hospital Association Leadership Academy. And I was at a conference where they had a panel of like Humana, Blue Cross Blue Shield, and a couple other insurance CEOs sitting in a room for West Virginia. And this has been something that I've been pushing for, but I told them the story about the denial and about how the prior authorization specialist switched the codes. And I said, you guys could help prevent this if your portal said this isn't a real code.
Yeah.
Uh, You know what I mean? Like
Yeah.
if a portal could say like double check your work, this isn't a real code, then it wouldn't have been a denial from a generic standpoint.
Yeah. And boy, just one thing after another.
Yeah. And my husband, he passed away in April of 2025.
Wow.
It's even before, like, for pretty much since that first time, he always told me, he's like, "What do people do who don't have a Tiffy?" Because he called me Tiffy.
Mhm.
"What people do who don't have a Tiffy?" And then I even had family members like, "He lived as long as he did because he had you fighting for him." And that was one of the things that really, stood out to me is even if you're a nurse, like I was fortunate enough to know about CPT codes and ICD-10 codes because
Mhm.
I was in a world that exposed me to them and I wanted to learn. But if you're a bedside nurse inside the hospital, you don't know what a CPT code is or a diagnosis code because it's not part of your world.
I guess, one of the next things that you did was, writing a book to help others, have navigate and go through all of this. I mean, what's I'm curious, what sort of was there any kind of feedback loop or follow-up from the health system? I mean, you were pointing out some things that would help your husband, that would help other patients. It was also helping the hospital. Did they thank you? Did they I mean, or they just thought they do you not really know what they did with that input?
The first time, like I said, I got a lot of gratitude and thanks from the physician herself.
Yeah.
Um, and then, of course, got a note saying, "Thank you. We are going to look into this," kind of thing that you get from the patient advocates.
Yeah.
Then, when it happened with the gamma knife procedure, so my husband unfortunately woke up the day after his procedure and couldn't put his pants on and couldn't write his name. And so I ended up rushing him to our local hospital, CT'd, and he had brain swelling that was crossing the midline. And so he ended up having to go to the facility and have an emergency craniotomy the next day. And I had filed a claim prior to all that happening and talked to the patient advocate and explained, like, I understand these prior authorizations take 2 weeks. And however, this one wasn't due to that. This is because clearly my insurance company said nobody hit submit. A week after all of this, we got a phone call from his oncologist to go to the hospital immediately that he was being admitted. Come to find out it wasn't renal cell that was in his brain. It was central nervous system lymphoma, which, yeah,
All
a whole
stating the obvious, an altogether different cancer.
altogether different cancer. I suspect that's what was in his eye the entire time. He had intraocular lymphoma, and we never figured it out because who would have thought you had two primary cancers? But intraocular lymphoma, I learned after it's untreated, goes into central nervous system lymphoma. And after he received the treatment for the central nervous system lymphoma, which is high dose methotrexate,
Mhm.
and he ended up having to be admitted to the hospital 8 times for a minimum of 5 days each time for the treatment. every other week, his vision actually got a little bit better.
Yeah.
And so, 'cause renal cell and central nervous system lymphoma have two completely different treatment paths. And so, he was a unicorn in so many different ways. But the day that we were walking or going to the hospital for that, I received a letter from the patient advocate that said, "Thank you for your concern, but prior authorizations can take up to 2 weeks." And I was like, you know what? I've got bigger things to worry about today. I just
Yeah.
did it because, yeah.
Did the Gamma knife procedure, was there just a bad outcome, or does that point to like something went wrong with that in terms of your husband not being able to function the way they expected the
It
next?
was because it wasn't renal cell cancer, it was
Okay.
central system lymphoma. Gamma knife never had been done had we known it was central lymphoma.
Okay. So this traces back to that shouldn't have happened. Would we call this a or like bad assumptions of not thinking it could be?
It's a little bit of both and human error. I mean, like, even as the wife and the nurse with the medical background I had, I would have never thought he had a separate cancer in his eye. You know, you very rarely hear of people who have 2 primary cancers that are completely unrelated, but in his case, he did.
So the human error, maybe a cognitive bias kicks in, even for very highly educated, intelligent people. I see you nodding there. If we assume it's very, very rare to have two primary cancers, there'd be a tendency not to even investigate that.
Yes.
So it's not like what's wrong with that person, that physician. It kind of go. It's not so simple.
It's not simple. His ophthalmologist and his oncologist were both wonderful physicians.
Yeah.
Highly recommend them to everyone because it was the integrative approach and the team approach that we had that really, I think, kept him moving on.
Yeah.
Because even then, like, his original oncologist specialized in, like, renal cell and a couple other cancers. Then we ended up having another oncologist who specialized in central nervous system lymphomas and different lymphomas and plus then the ophthalmologist. So it was a whole team that worked to keep him alive as long as we had him.
Yeah. Ah, that's a lot to think about. Just the tragedy enough of a spouse dying of cancer, but to think about the different challenges and hearing about the bureaucratic errors, if you will. I don't want to say that's not it's not important, but it hits differently than, hearing about the diagnostic error and the treatment error that resulted from that. And he had a lot going against him, unfortunately.
He did, and he was very strong even before he even had a heart attack right at the beginning of his treatment before the
Mhm.
keto. He started a one of the targeted therapy pills. And he was just had his second pill and called me and he's like, I don't know what's wrong. I think I'm having a heart attack.
Mhm.
Really worried because of the medication, and I was like, "Okay." But he ended up having a heart attack, and ended up going back to the facility where he's receiving his treatment from after it was diagnosed at the local facility, and it wasn't associated with his cancer medication at all. He actually had an 80% blockage in the LAD,
Mhm.
a pretty significant blockage that had been quietly building up, and
Yeah.
that was taken him. But, we had some issues when he was admitted for that too, I write about in my book, because he was on an oncology floor because he was an oncology patient, but he was having treatment for cardiology. One thing I learned sometimes when you get bigger and bigger in the hospital systems, people talk less and less. And so, he was admitted on a Friday, and then on Saturday, they took him down and did a heart cath, and that's when they found the blockage, but they didn't treat it. So they brought him back out and said they didn't know what they were gonna do because they needed to talk to oncology. So 24 hours later, oncology still hadn't talked to cardio, and I was getting a little irritated because 'cause I'm like, "What's going on? What's the
Right.
plan?" And I was thumbing through their patient handbook, and, I came across that this certain facility has a code HELP, and, different facilities have different codes, but theirs is called HELP.
The code that someone can call, can activate.
Yes, and family members can activate a code help whenever they feel like treatment's been delayed or if things aren't going well. So it's something not just for like nursing staff, but more geared towards family. And it wasn't something like people were like, hey, you can use code help, but since I actually picked up the book because I was bored and was reading it,
Really?
I we had been all day, like, "When is oncology gonna talk to cardiology?" Like, "You guys are in the same hospital. How hard is it to sit down and make a decision
Yeah.
with each other?" And so I put his light on, and of course, he's mortified, and the nurse comes in, and I'm like, "Hey, I was just reading in here that you
Yeah.
guys would help. Do you think if I use this, that maybe cardiology and oncology will talk to each other?" Right. Oh, I did, and within 10 minutes, oncology and cardiology were both sitting in our room talking and making it
Yeah.
for the next day.
Yeah. And I've talked to a lot of patients and patient advocates who describe the reaction like your husband had of like, they're going to think we're troublemakers from your experience, and that you have to speak up. It's not that you have to, but it can be beneficial to speak up, even if a lot of people are afraid to. So let me pivot a little bit to I wanted to ask about your experience working in healthcare, Tiffany, because you described yourself as you used the phrase pain in the butt employee, somebody who challenged things and questions things. And like from what I hear you describing here, you're knowledgeable, you're being patient centered, in this case, the patient being your husband. You're doing, I think, right things for the right reasons. But I mean, was that phrase thrown at you by a manager of like, Tiffany, you're a pain in the butt?
They never said it. I was
Well,
very
not
fortunate.
correctly anyway.
Yeah, so most of my career in the same healthcare system, I had the same boss for years, and she was wonderful. She was a mentor, she helped me grow, and, she decided to move on, and she always challenged me to learn new things. Like, when I became the population health nurse manager, this was back in 2017, and population health was a newer concept. Annual wellness visits and, chronic care management and those kind of services, and that's one of the things that we really focused on. So I dug into it and would learn, what are the codes? How do you bill for them? What do you need to have in the chart? Because I always felt like if I didn't understand it, then how am I going to expect somebody else to? Or, and I know, or at least have an understanding, because if they're reporting to me, I need to know what they're doing
Mhm.
to know that it's being done right. And I had always kept that kind of thought process. I, would work closely with billing department to see if things would, improve. And one of my last meetings, because I actually ended up leaving my job, not because of this, but just life in general and taking a different path for a while.
Yeah.
Um, made a suggestion, why don't we get our general surgeons to sit down with our billers every time there's a big denial? Because a lot of times your surgeons don't understand why there's a denial. They're not even there's a denial.
Yeah.
And then, maybe if it's an error the surgeons are doing with documentation or something, then we
Mhm.
correct it so we don't have these.
Break down the silos and learn from it. And like, yeah, that's
The
great.
response I got was, Don't you worry about that. That's billing's issue."
Ah, yeah.
And so that's when I realized, I'm like, maybe not everybody likes somebody that pulls people together. But yeah, I always felt like even if I was a nurse, nursing for me wasn't the only part. Like, I learned how to operate our EHR inside and out.
Mhm.
Because I
Electronic health record for those who don't know the
sorry.
term. Yeah. Yeah.
Yeah, the electronic health record. And so, it was just how I'm built. I need to know the why and
Yeah.
the how, so that way we can look for ways to improve, because you can always improve as well.
Sure. Though when you became a leader, a manager and a director, were there things that you did as a boss to help people feel safe challenging things so that they didn't feel like they were a pain in the butt, that they were welcome to challenge things?
Yes, I always encourage people to bring up, ways to improve things. And just because something isn't broken doesn't mean that it can't be improved. People have that attitude, if it's not broken, don't fix it. but that's kind of also insanity because there might be a lot better way of doing the non-broken.
Yeah.
And I also, whenever I was working with my employee, I always tried to make them feel comfortable to come tell me anything. I know I had a nurse one time come to me. She'd been working with me for a couple months at this point, and she came and told me something. I can't even remember what it was. And I was like, "Did they die?" And she looked at me. She goes, "What?" I said, "Did they die?" And she's like, "No." I said, "Then it's okay.
Hmm.
Like, it's gonna be all right. We can
Yeah.
work through this. It's not nothing that's going to, like, be catastrophic or, we can work through whatever this issue is." And I learned, though, later that her previous employer was one of the ones, like, if you use the pink sticky note instead of a yellow sticky note, you were getting written up. And so
It's very micromanagey, right?
very micromanaging, and so I never really felt like that was me.
Sure.
I like to help people learn to grow and be independent and, think for themselves.
Yeah. Yeah, when you think about systemic errors in healthcare, sometimes people will report a near miss or a problem, and I've heard people, kind of use that phrase of like, "Nobody died," or "Good catch," and there's the pat on the back or the formal recognition, and then as an engineer, I think, "Well, okay, well, now what?" Like, we can still learn from that even though, yeah, it's good you caught it, it's good
Mhm.
nobody died, but what if the next time somebody's tired, distracted, the same thing could lead to something the same issue could lead to something catastrophic. We
Yeah.
can't replay the outcome, if you will. We gotta think about, like, what could have happened. And I
Yeah.
found sometimes people don't like to think about that almost in a superstitious sort of way of like, "Well, we don't like to talk about these things." I'm like, like, it seems like you should."
Having those discussions, the what ifs and the could haves are a way of making sure that they don't happen.
Yeah.
We always say repeats itself, but ignoring the inevitable, if it happened once, if you don't address it in a way, it's
Mhm.
gonna happen again.
Yeah.
That's
Yeah.
just going back to the oncologist who was so happy that I figured out what was going on. Because how many times had this happened before? How
Right.
many were patients were denied their treatment because somebody switched an ICD-10 code with a CPT code?
Yeah. Oh, so let's talk about the book. Again, our guest Tiffany Auvil. The book is "The No BS Guide for Caregivers." It's available now. "How to Survive the Healthcare Maze" is the subtitle, and we've, gosh, heard a lot about not only the clinical maze but the administrative maze that you and your husband and a lot of us have to navigate. With the book, we say yours is a no BS guide. It begs the question: is what would you consider BS that's told to patients or caregivers? What BS were you trying to avoid?
I was wanting to not avoid so much as be real when it comes to being a caregiver. You really wanna help the caregiver support that's out there is how to help, I guess, yourself. Mindset, meditation, which trust me, I have all my own mindset and meditation things that I practice because I need those things too.
Yeah,
But I wanted to give people tools that could actually help them help the person they're caring for.
yeah.
And when I was helping my husband and we were going through that, I gained a lot of weight. I actually went up to 267 pounds, which was the heaviest I'd ever been. And I always said, I don't care if I'm getting fat. I've got too much to deal with. I'm not worried about it. I'm going to take care of him. And, whether that's right or wrong, when he passed away, then I was able to start saying, "Okay, now let's focus on me and,
Mhm,
myself healthier," which I've been doing, and I've lost about 60 of those pounds, which is
mhm.
great.
Yeah,
Yeah. But what people really need is how they help, I don't wanna say improve, but make things better for their loved ones. So, like, my book goes through a little bit about organization because I don't think you can navigate the system without being organized. But then I give them tools about how to talk to a doctor,
yeah,
how call your insurance company, a little bit of information on how billing is. People get really stressed out when they get a bill from their healthcare provider and they see 2 separate bills because they're getting a professional fee and a facility fee, and they don't understand why.
yeah.
Mm.
Right.
And so it breaks down those things of really being in the system and then how to appeal a denial, how to talk to the insurance company to see if you can help get a denial overturned, or is it really even a denial and like what we experienced. And then I end it with, which I think people are really sometimes afraid to talk about, is the terminal side and the end of life side. My husband, he was one of those people, hospice meant the end is near. And so it was before and the thing with my husband, like he was riddled with cancer, but up until a month before he passed away, he was outside working in his garage on four-wheelers.
Mhm.
So he was a healthy, I guess you say, very
Oh,
active cancer patient.
right.
And he got tired easily, but he was still, just doing everyday life to the best of his ability. And in December, before he passed away, we got a PET scan that showed his cancer was spreading more in his abdomen. And there was a radiology report that came back that there was a tumor invading his colon. So at that point, I told him, I was like, look, we need to start hospice, not for you, but for me. And because I'm going to need them when the time comes, and I don't be dealing with paperwork when the time comes. And so having had that conversation, we started what I call decaf hospice. We had it in our area where it's more
Yeah, right. Decaf.
decaf. We called it decaf, like half hospice, because they don't come in every day. They don't see
Yeah.
you every week. A nurse practitioner may call you once a month, but you're in their system and you already have all your paperwork in. And when we found that his central nervous system lymphoma had returned in his brain, he decided he didn't want to do treatment again, and that this was his decision to say, "Okay, I'm done." And I called hospice immediately, and they were able to come in and start helping.
Yeah. Yeah. And hospice or palliative care doesn't mean no care, but correct me if I'm wrong. It's more about comfort at that point. We're not trying to actively get rid of the cancer, but let's keep the patient comfortable, focus on quality of life at that point, right?
Some treatment of the cancer still part of it. My husband, he was
Ah,
still being treated for his cancer and doing all the things up until he decided he didn't want to have the treatment
mhm.
anymore. He even was still taking his targeted cell therapy pills for the first almost, maybe 5 days after we learned that his central nervous system lymphoma had returned. And when he decided to stop that medication, that was on his decision.
Right.
But hospice came in and they provided me with, support and, emergency medication kits for when he became ill or in severe pain, that I had something available to give him without having to drag him out of the house, go to a doctor's office, find a pharmacy. It was
Mhm.
there ready.
Yeah. And, in the book, it's just at first glance, I mean, we talk about tools and practical things that people can use. I mean, maybe a lot of this comes from the discipline of nursing, checklists, scripts, worksheets, quick reference guides. I mean, it's very much a action oriented book, not just something to read and contemplate, but actually bring with you to appointments, to the hospital, and put it to use, which is great.
Yes, and I even say in the beginning of the book, like, you don't have to read this from front to back. It's not
Mhm.
made that way if you don't want to read it. You can look at the table of contents and see appeals or denials and look in there and say, "Okay, this is where I need to go to for today."
Yeah. Um, and maybe as a final question, because one thing in the description of the book that stands out, there's knowledge of knowing what's the ICD-10 code, the diagnostic code. There's a lot of lingo, acronyms, Latin terms. If someone says like, "Oh, your husband's got to be NPO tomorrow," and what the hell does that mean?
Yeah.
No food, clear liquids only, right? I mean, it's like NPO. It's a Latin. It's a
Yeah,
Latin phrase,
not
right?
yeah,
I mean, yeah. I mean, nobody. It's just NPO.
and
If you're like,
that's how we learn it.
so to translate some of that to patients and families is important. There's the knowledge layer, but maybe as a final question, there's maybe like what to say to a doctor, but as you point out, there's more of like how to speak to doctors in a way where you're more likely to be heard. What advice do you have about the how?
I always suggest that you talk to them. And when you go into like, so the biggest thing is when you go into a doctor's appointment, and this is something I've seen in years of primary care, people come in and they've got 15 things going on. And they want that doctor to solve all 15 of those problems,
Mhm.
15-minute office visit. You could read it with your
Yeah.
doctor.
Right.
I want people to realize that that's not practical.
Mm.
So whenever you go into a doctor's office, you really need to pick the top 1 or 2 things that's bothering you at the time and
Mhm.
make additional appointment for the rest if needed, or utilize the portal if there's one available. You can send questions over instead of saving it all up for the doctor's visit.
Mhm.
And then also realize your doctors. I live in a very small town. There's only 1,300 people in my town, and my entire county in West Virginia only has 6,900 people,
Mhm.
or most national forest. But people still talk about Doc Pete Michaels, who was the house doctor 30, 40 years ago that knew everybody in the town. He
Yeah.
delivered for the town. But doctors really aren't like that anymore. They
Mm.
have patient load of a minimum, I'm sure, 2,500 to 5,000 patients. They've got all kinds of information coming to them from insurance company through agencies like CMS and accrediting organizations like the Joint Commission and DNV. And they're trying to keep all of that together and manage their patients at the same time. So you can't expect your doctor to know everything about you.
Sure.
But you need to be available to talk to them and explain you again.
And help them help you.
Yes.
Yeah. Because, we're all human, regardless of what letters we have after our name for our degrees and certifications and fellowships and everything. We're all human. Nobody working in healthcare is superhuman. People are fallible, but boy, trying to help people. I think the one thing we see, I think very similarly from our different backgrounds is we've got to help people help us, and part of that is doing things that can prevent mistakes
Yes.
is going to help everybody out.
Yes. And finding the errors that may have caused the mistake, like you said, the near misses or the good catches, and not just saying congrats, but actually working to improve it so it doesn't happen again.
Exactly. Exactly. So thank you again, Tiffany. Tiffany Auvil is our guest today. Look in the show notes for links to the book. It's available now. The No BS Guide for Caregivers: How to Survive the Healthcare Maze. Congratulations. Sometimes publishing is a maze. Yeah. Congratulations on getting that to the finish line. It's available now. The reviews are really good. And, I'm looking at Amazon, and it's funny here. And it's clear on the title, but this is an Amazon glitch. It says it doesn't capitalize BS. You've probably know the, the no B's guide to caregivers, which is maybe a different meaning. It's clear on the cover, no BS guide. So, Tiffany, again, congrats on the book. I know it's going to help a lot of people.
That's
Little important mission. So thank you for that. And thank you for sharing your story and your lessons learned today.
Thank you for having me on and allowing me the time to talk with you and your audience.
Of course.